I've started our recording, so now we're getting started. I'll hand it off to Lisa.
Hi, everyone who's joining us today. I'm Lisa Dailey. I'm the Executive Director of Treatment Advocacy Center, and I want to thank you for joining us and for being present for both my, kind of chat about what we've been working on this year and for being able to attend our Q&A at the end of this. We're going into the week of Thanksgiving, so it's a good time for us to communicate how thankful we are for all of our supporters. Treatment Advocacy Center supporters are among the most engaged of the individuals that we've worked with in various different settings. I've really never seen supporters who approach the work with as much gusto as those that we know through Treatment Advocacy Center. And that's because of how passionate we all are about the work that we're doing. These are not theoretical issues for many of us. They're personal issues. Many of us are working for people that we know, or we're working in memory of people that we've lost. Earlier this year, which now feels like it was about 10 years ago because of the time warp that COVID has placed on everything. Some of you may have attended a virtual town hall meeting that I hosted. During that event, I outlined some of our plans and some of our goals for the year. And we obviously plan to continue to do all the things that we've always done. So, obviously we're still planning to put out research and reports and anything that's specifically relevant to families who are affected by severe mental illness. We were going to continue to work on legislation at the state and federal level that are specifically targeted towards getting treatment to our loved ones at the right time, not waiting until the last minute when people are already at crisis. And then also working on providing hands-on technical assistance for programs that are implementing AOT, both new and existing programs. But last year, I also identified two major areas of focus that we were going to concentrate on in the months to come. And those two areas of focus were on partnership and on reach. And so over the course of the year, our team's been working really hard on improving our performance on both of those kind of aspects of what we work on. And I wanted to share a little bit with you about how we've gone about doing that. So with respect to partnership, my commitment to you, to our supporters, was to do a better job of keeping you in the loop about the work that we're doing and to provide more support and more resources for our local partners and to be able to engage locally on the issues that we all care about. And our goal has been not only to help you engage with our work and to be a part of the advocacy work that we're doing, but to give you more tools and more knowledge to be able to use, to promote our shared goals on every level. So that, that's county and state and national and federal. Obviously, we know that we can't be everywhere, but our supporters can if we have enough of them. And we want you to be prepared. We've all been working on this goal, but I want to give a special acknowledgement to Michael Gray, who's been working probably the most directly with a lot of our collaborative advocacy efforts with our local partners. A lot of times if people reach out and have questions about how to get involved with advocacy, at their local levels, you will probably speak with Michael, or he will help you with, sort of some of the ideas and troubleshoot ideas about how to approach certain issues. We put a lot of effort into communicating more frequently and in more detail for our supporters to kind of have a better idea of how they can be involved in the work that we're doing and what is the easiest and most effective way to be involved on various different issues that we're all caring about. And then we've also worked on developing and distributing resources that are easily shareable, things that can be downloaded and shared with your local officials and with your state level lawmakers. And really just any tools that make it easier for our collaborative advocates that we work with at the local level to be able to, really advance the goals that we all share. There are a lot more of those kinds of resources that are in production. So I'm going to just suggest that you stay tuned for even more tools that we have that are available for your own advocacy, plus more events and more educational opportunities that will help with that as well. Kind of the other aspect of our focus that we were working on this year was reach. And for us, that means basically kind of our investment in grassroots advocacy is in a way that we hadn't done before, based on conversations that we that we've had with our late friend, DJ Jaffe, and our founder, Dr. Torrey. Dr. Torrey endowed a position to honor DJ and to carry out the shared vision that they have of growing a grassroots advocacy base for Treatment Advocacy Center. So what does that mean? It means basically at its core, grassroots advocacy involves expanding the number of people who support and promote the same things. It means reaching new people with the message that we all share and inspiring them to join in our work. A certain amount of grassroots advocacy has always been a part of what Treatment Advocacy Center has done, but prioritizing it and kind of expanding it is a new thing for us. And unlike groups like NAMI, who have local chapters throughout the country, many NAMI groups, there's more than one group of NAMI in almost every single state. And so as a result, they kind of have a built-in grassroots advocacy base, and Treatment Advocacy Center doesn't do that because we are not a membership organization. So, for us, we knew that expanding our grassroots advocacy was going to look different than it would for a group like NAMI. So in close consultation with Dr. Torrey, we decided that our first DJ Jaffe advocate was going to concentrate on expanding the reach of our message and our resources into communities of color. And these are groups that are traditionally underserved and underrepresented in most spaces, but certainly also in the advocacy space. And in our conversations, Dr. Torrey agreed that DJ would probably love that idea and would particularly want to support efforts to engage with all communities. In particular, we know that DJ would be very happy with the work of our first DJ Jaffe advocate, Sabah Muhammad, because Sabah actually came to Treatment Advocacy Center through DJ. He was introduced to, he introduced Sabah to Brian Stetton, who brought her into the organization as a law clerk. And then we worked with her for many years. And then eventually she joined our team. And I know that DJ was very happy when she joined our team and actually wrote an email to her to reach out and congratulate her. And I know that Sabah is always mindful about how to honor DJ's legacy with the work that she's doing. And one thing that we know about SMI is that it doesn't discriminate. It affects all communities. There are families in every community who need to figure out how they're going to grapple with having a loved one or being a person with severe mental illness within a system that really does a pretty terrible job of treating it. And Sabah, within this project, Sabah is tasked with two separate but related goals. And the first is that Sabah is providing a platform for families of color to share their stories. What all of these families have in common with all families affected by severe mental illness, but also what is unique and what is deserving of attention for communities of color specifically. Some of you may know that Sabah has been working on a podcast series that is going to be sharing the stories of families of color who are affected by SMI. We have found that this is actually an enormous undertaking, probably bigger than we actually even expected it would be. It's probably one of the biggest projects that we've ever embarked on at Treatment Advocacy Center, but we're really excited about it and think it's going to be just an amazing resource once it's available. And SPA has been interviewing and researching and writing scripts for months. And, we're learning as we go. So we're really looking forward to rolling our episodes out. Still basically everything is in production, and it's turned out to be just an amazing scope of a project, and we're really excited about it. So we really, we will certainly promote it as soon as it's ready, and please be on the lookout for it. The other goal of Sabah's work is to reach new communities with our resources and policies. And we do this because we know that families affected by SMI need information and support. I can remember, as I'm sure many of you can, the first time that I came across Treatment Advocacy Center's reports online, just in, kind of searching for, I don't know what I was searching for at the time, but I came across a Treatment Advocacy Center report. And I remember what it felt like to read something that actually finally was talking about the experience that my family was having. It wasn't couched in, broad and euphemistic terms. It was really specifically geared towards the experience of a family that's affected by severe mental illness and those specific things that go along with that. We want all families to be able to find our materials and have that aha moment when you realize that there are other people who do get it and that you're part of a community that can help and support you. So we've hosted multiple webinars that are specifically addressing families of color. Sabah has spoken at events that are hosted by others with the idea that we want to extend the reach of our messaging and our resources into new communities, and we want to put Treatment Advocacy Center on the radar of more families and more advocates of color. And also, in collaboration with our excellent and hardworking communications team, we've started to make materials available in Spanish, with the ultimate goal of extending our reach into even more communities and in more languages, so that as soon as we can, we're able to reach even more people who are desperately in need of this information. Having an explanation for anosognosia, for example, is something that having that in your own language would be a game changer for a lot of families. And there's no other organization that is going to do that if we don't. So that's something that we're definitely intending to continue expanding into, and definitely always looking for volunteers that can help us to review materials and make sure that the way that we're putting things is culturally competent and something that really is useful for the communities that need those resources. I'm going to go into just a few of the specific ways that our teams have been working on being good partners and extending our reach over the course of this year. You will probably have seen a lot of different webinars and announcements where a number of staff members from really almost all of our departments have spoken at various events or conducted webinars on some of our key TAC issues, many of which are specifically, kind of designed to jumpstart the advocacy work of our local partners. And the topics of these have included things like HIPAA reform and IMD reform, Advocacy 101, which Michael Gray did, to kind of give people an idea of how does this work? And, what if you haven't really done this before, what does the process of advocacy on legislative issues look like? We've certainly spoken a number of times about hospital beds and the need for more of them. And we've participated in discussions about telehealth and SMI and what those issues are. We've addressed particular state issues, such as when Brian Stetton discussed AOT law changes in Louisiana as a panelist for Janet Hayes and Healing Minds NOLA. And we met with California advocates to discuss changes to Laura's Law, the version of AOT that exists in California, and what those changes are going to mean for their advocacy and how they need to adjust in light of new law changes and what the requirements will be for that. The implementation team has provided technical assistance for AOT programs all over the country, in consultation a lot of times with family members who are kind of experiencing the new AOT programs and helping us to identify where things are not working or what kind of things we might be able to do. And in my view, the implementation team probably doesn't get enough attention for this work that they're doing because it's not really a generally publicly facing thing, because it's really in the weeds and in the trenches working with specific programs. But Betsy, Amy, and Brian are quietly working in 40 states, at least in a virtual capacity, to ensure that AOT programs are structured in a way that allows them to succeed. Our Office of Research and Public Affairs, which we affectionately refer to as ORPA, produced a survey in partnership with Clubhouse International this fall on efforts to improve COVID vaccination rates for those with SMI. This was really the first time that we've ever partnered with Clubhouse International, and it was really a great experience. Hopefully not the last time that we'll partner with them. It was really, a very interesting experience, and we really were able to develop results that are useful in a lot of different ways. We were able to showcase ways in which clubhouses were able to work collaboratively to troubleshoot and kind of identify ways that they could increase vaccination rates for people who were Clubhouse members, which is really important because the research has been very clear that those are populations that are specifically very much at risk if they are to become infected with COVID. So that was a great report, and we're hoping to be able to partner with Clubhouse International on other things. The ORPA team is partnered with the implementation team in order to ensure that data collection is included in the AOT implementations in a lot of different places so that programs have the opportunity and the ability to meaningfully evaluate the results. And I want to give a shout out to Elizabeth Sinclair Hank, who has really been my key partner in our national efforts to push states to prioritize vaccination for people with SMI, in demanding that the CDC recognize that schizophrenia should be listed as a high-risk population for people with basically, the research has been very clear for quite a long time that individuals with schizophrenia are at a very high risk for serious illness or death if they become infected with COVID. And that was something that really, it seemed like for kind of a long time that we were sort of a lone voice in the wilderness trying to cry out for this to be recognized by the CDC, which we were finally able to achieve. And I really want to thank Elizabeth for providing the research basis that we needed to be able to make that argument. And then, of course, in partnership, and it's inspired by Dr. Torrey and his efforts to really kind of call out NIMH proportion of research for clinical trials, we also have been working very hard to ensure that there is a prioritization of research, especially clinical research for schizophrenia and for other SMI diagnoses. And then, our communications team has been quietly involved in really all of our work. But most visibly, they've partnered with our implementation team to produce our first podcast, which is called The Way Forward. Really talks quite a bit about AOT in Ohio, and then is something that is generalizable really to any community that's looking at whether or not they want to invest in AOT. It's a shareable resource. You can send it by link. It's available in various different podcast platforms, and it's been very well received, and it's been a great tool in trying to persuade people that this is a valuable resource and it's something that has a lot of potential for all communities. Also, just, like many of you will have been in contact with our communications teams and working on kind of an increased push for storytelling as a key tool for advocacy. So we've had the opportunity to share and, the honor to share people's individual stories through our Personally Speaking blog series, which is, in my view, some of the most important work that we do in being able to really give a voice to our family members who really want their story to be illustrative and for people to be able to learn from the experiences that they've had so that they can have good results or better results than they were able to achieve within our very broken system. I've already talked a little bit about our advocacy department and the work that our advocates Sabah Mohammed and Michael Gray have done, but I want to take a moment also to mention a couple of new members of our advocacy team and why we believe that they're going to be transformative additions to our work. And this is because they are in new roles that will be expanding the work that we're able to do and really increasing the kind of the quality of the advocacy that we're able to do. Clara Keene joined our advocacy team recently as our legislative advocacy manager. So apart from taking on the primary role in our organization for tracking legislation and kind of making sure that our advocacy and implementation teams are up to date on what is going on at the state and federal level with new bills that are being introduced all the time, she is most directly involved in communicating grassroots information to those of our supporters that are interested in being a part of our advocacy. So if you receive an email, or if you see a tweet, or if you see a Facebook post that includes a link that allows you to take some kind of an action, it almost certainly will have been generated by Clara, probably in partnership with our communications team. And you'll also probably soon be seeing her inaugural newsletter that we are going to be putting out. It's our basically first attempt at an advocacy newsletter that is going to be geared at keeping our supporters up to date on what is going on with bills at both the state and the federal level and other policy issues that are particularly of interest if you want to be involved in advocacy. So we're looking at launching that in the new year. And I just recommend that you keep an eye on email because it will be put out and there'll be an opportunity for you to sign up for it in various different places. And I think this is going to be a very valuable tool. It's something that, I think we really have seen a lot of demand for this among our supporters to be more informed about what is the legislation that they should be tracking and what should they do when things are available. And this is going to be one of the things that Claire is going to help us keep up to date on is, she's going to be tracking legislation. If it's key legislation that we're really interested in following, she's going to be able to send out alerts and let people know that, hey, there's a hearing on a bill that's of particular import that is in Ohio, for example. And this will give you an opportunity to be involved and to submit testimony or to be, active in the advocacy around that issue. So we're really looking forward to that. And then Kathy Day recently joined Treatment Advocacy Center as our senior family liaison. This is a function that we've really always had with Treatment Advocacy Center, but we're now going to kind of put together more of a concerted resource base for this function. And it really allows us to bring in a trusted advocate that we've worked with and referred calls to on many occasions in the past. And she's going to be joining us as a staff member who's really going to be able to share her expertise in helping families really navigate the system, both on a crisis or a non-crisis basis. Kathy is the one who's taking the hard calls and taking the hard emails and talking with people who are really trying to navigate our mess of a system. And we're lucky to have her as a resource. And we're really looking forward to working with her and building out our resources so that we can do the best job that we possibly can in making resources available to family members who are in crisis. It's always been a big part of what we do. And we're really looking forward to kind of having a more defined function there, and to be able to provide more and more and more resources for the families that are looking for it. Because as many of you will know, the information that is sought by families who are affected by SMI is not always the same as what is available from some of the other organizations. And really, we want to be available as a resource as much as possible. So this is not everything that we've worked on throughout the course of the year, but it's some of the highlights that I wanted to share with you. And I know it's probably a little bit early, but I think it's probably time to jump into some Q&A. So with that, I'll invite Renee to hop in.
All right. So anyone who would like to submit a question, if you haven't already done so, you can use the Q&A function at the bottom of the screen. And I have a few that have already come in when folks registered, so I'll start with those. We had several questions come in about IMD exclusion. So maybe you can just sort of talk a little bit more about where the IMD exclusion is at, and folks seem to want to know a little bit more about psych bed creation and things along that line.
Sure. And I will just give a shout out to Michael Gray, who recently did an IMD webinar where he was basically talking about advocacy around this and what should you do and what is the reason why you would do various things. So I'll recap the highlights of that, but Renee can put in the chat the link to that event, because it really does provide a lot more detail about kind of how to get involved with that. But essentially, I'm assuming that everybody's basically familiar with what we mean when we're talking about the IMD exclusion, but I'll just give a really broad overview just in case you're not. So the IMD exclusion is basically a clause within a law that forbids the use of Medicaid funds for inpatient treatment beds in facilities that are larger than 16 beds. So it's one of the biggest curbs on being able to build new facilities at the state level, because it disallows federal Medicaid funds to pay for it. It is the only kind of limitation on Medicaid funds in this area. So you would never obviously find that Medicaid is forbidden to pay for any kind of treatment in an inpatient basis for people who have heart disease. It is something that we consider to be extremely discriminatory for whatever reason, whatever the reasons are that IMD exclusion exists. It's discriminatory. It applies only to people that have mental illness and might be in inpatient treatment, and it needs to be repealed. So what's going on with it? And it's been, it's obviously been on the books for a very long time. So it's not a new effort to repeal it. But basically what's going on with it is that there's really two prongs going on in the advocacy around it. One of which is that there is a viable bill. It's not clear if it's viable right now in the short term, but there is a bill that does propose to repeal the IMD exclusion. It's HR 2611. It's sponsored by Grace Napolitano. And it's something that, the language, it does actually accomplish a repeal. So we encourage people to support it. And what we have asked people to do is to encourage their lawmakers to sign on as co-sponsors for the bill, so that if it doesn't get anywhere within this current legislation or this current legislature, that it is something that can easily be re-upped in the next legislature with, once somebody is signed on as a co-sponsor, they're much more likely to be ready to co-sign again on the next iteration of something. So we encourage people to do that. And then the other thing that you can do now, kind of regardless of what happens at the federal level, is we do know, there are waivers that are available. They're called 1115 waivers, and we kind of refer to them as SMI waivers to the IMD exclusion. They are available at this point, and there are a number of states that have already applied for them. Some of them already have been approved. And what it basically does is it allows states to apply for an exception so that they can use Medicaid funds to fund state, they can fund beds that are in IMDs, which is, the facilities of 16 beds or more. And the reason that this is important, even though it doesn't fully accomplish a repeal of the IMD exclusion, is that it will give us an opportunity to gather data about cost savings. We know that the idea that there might be a crippling fiscal note attached to the IMD repeal is one of the main reasons that it's been tough to get momentum on this. Just kind of the speculative assumption that it's going to be astronomically expensive. But what we're finding is that at the state level, the data doesn't necessarily support that. So the more states that have applied for this waiver, the more data we're going to have available to kind of show that, hey, this does make sense from a cost perspective. So that should not be a reason why you don't go forward with repealing this discriminatory legislation. So that's kind of the overview of what's going on with IMD advocacy. And I would just encourage people to watch the webinar that Michael put on. There's also a piece at the end by Jeffrey Mulata, our communications director, kind of talking about how you can get involved as far as like writing op-eds and changing minds in that way. So that's kind of the overview of what's going on with it.
Fantastic. And I just put a link to the section of our website where you can see the IMD bill that Lisa was just talking about, but along with all the other bills we're tracking right now. And that's a new function on our website, courtesy of Clara, I believe. And that's all the work that she's working on right now, which is fantastic. All right. So Glenda in Oregon submitted a question that I'm sure lots of folks have some curiosity around or have similar experiences. Says, what can parents and loved ones do for a mentally ill person who is not a minor, who doesn't recognize they are ill?
Well, that's the $1 million question, obviously, that a lot of us have faced. And honestly, there is not one answer to that question, because we live in a country where there are 51 different systems, and none of them operate the same. And it's not even the same from county to county within the same state. I think the best suggestion that I can make about that, apart from talking to Kathy Day, who is really kind of a miracle worker and figuring this out, is know how your system is supposed to work where you are, and then keep trying to demand that it actually works that way. So that can involve knowing what your criteria are for involuntary admission to a hospital, knowing what the process is supposed to be. So like there are definitely some places where you can make a referral directly to your behavioral health department, mental health department, in order to kind of refer somebody to be evaluated for care. There are some systems where really the only way that you can be admitted involuntarily involves needing to have the police involved. And one of the most important things that you can do is be aware of how your system functions, and then try to get your system to function the way that it's supposed to. And it is not easy. And I'm certainly not going to suggest that it always goes the way that it's supposed to, because we all know that it doesn't. But it is definitely a valuable thing to know how it is supposed to operate, both on a systemic basis. So like, this is the process that you're supposed to go through if you're going to have somebody maybe admitted involuntarily, or just understanding what the criteria are, or understanding like I know that there are family members that will bring with them a printout of what the exceptions are for HIPAA disclosures, so that you can argue with people who try to tell you that they're not allowed to release information. So a lot of it really has to do with, unfortunately, needing to become an expert on the system in a way that a lot of the people who work in the system are not as expert as they should be. So that's probably the top advice I would give you, is to figure out exactly how it is supposed to work, and then do your absolute best to try to force it to do it. Oh, you're muted. Renee, you're muted.
Sorry, I thought I got myself. So we have a question sort of along that same line that I thought made sense to answer right now. It's Bessie just submitted a question in the Q&A function, wanting to know, understand that we're not a grassroots organization, but what kinds of information or support service can your organization provide to many immigrant families in New York left alone without much help? I'm assuming that's Sabah, right? Like, so.
Well, I mean, we're going to be looking at making a lot of resources available in a lot of different languages, which is one of the reasons why, we're hoping to do that as quickly as possible, because we definitely recognize that it's not really as useful to hear advice in not your native language, especially in something that involves medical terms and involves a lot of terms of art that means something specifically. I mean, we have seen as advocates, people argue over the meaning of 2 or 3 words in a statute many, many times. And obviously, if you are in an immigrant population, especially if you don't speak English as a first language, that is not necessarily the easiest thing to tackle. So that's among the first things that we are looking at doing, is to make things available in other languages. And I would just really encourage that if you're finding that there are hurdles in your attempts to get care for somebody, and you believe that it's really relevant to being a member of a community that is underrepresented or where you need assistance, then I would encourage you to reach out to Treatment Advocacy Center directly, and to really help us, have us help you troubleshoot that issue. We certainly have been able to do that in some circumstances, either through our helpline function, with Kathy, our senior liaison, or sometimes we're able to do that with the advocates and kind of trying to help navigate how to go about approaching a system. We can sometimes help find resources that do exist but are harder to locate if you don't know exactly what you're looking for. So that's what I would suggest.
All right. We have an anonymous attendee who submitted a question: how can TAC assist AOT programs struggling to find stakeholders willing to participate and contribute to the process?
Well, I mean, I guess, I would first identify, Betsy as an excellent secret weapon in that department. Betsy is really the person who does a lot of the on the ground work of kind of wrangling together the stakeholder groups that participate in kind of setting up a stakeholder group to both plan and then implement an AOT program. So I would first encourage people who are having that kind of a struggle to be in touch with our AOT team and see what you can do. And then I would say that, like, really what you need is visibility for an issue like that, because there will be people in any community that need AOT or whose loved ones could benefit from AOT, but they may or may not know that. They may not know that such a thing exists. They might not know outpatient civil commitment is actually a thing that they could be pursuing. So a lot of it is getting more visibility around the issue. So, I would suggest, outreach in terms of like getting in touch with groups who may have an interest in this, talking to law enforcement, talking to your local NAMI groups or any other support groups where you're likely to find people who might be within the group who could benefit the most from AOT. And then a lot of it is, like if people write letters to the editor, if they write opinion pieces, you can really kind of attract interest when people can see that there's this initiative and we're looking for people to get in touch with us if you're interested in implementing. So that's definitely something that I would also suggest, is taking advantage of letters to the editor and opportunities to post things publicly so that you can attract the attention of other people who would be interested in the same thing.
All right, we have several questions that were submitted in advance of the meeting around mental health bed shortages. And then we just had a question come in. This came up in staff meeting just like maybe 2 weeks ago about the lifetime limit of residential psychiatric treatment under Medicare. Sonia writes, this impacts those with complex needs. Is TAC tracking this data? Is this needed to expand state hospital beds and our public mental health care system? So I think just sort of beds in general.
Yeah, I mean, the lifetime limit on on Medicare is tied very much to a lot of the other like artificial and discriminatory limitations that exist on individuals with mental illnesses. It's basically what it is it's basically kind of discrimination that's based on the idea that healthcare that's provided for a mental health diagnosis is different in some way than it is for any other kind of physical illness. And there is a bill that's been introduced very recently that actually would get rid of the lifetime limitation, which we certainly support. And we'll be sending out, we're tracking that legislation, and we'll be sending out information on, when there are opportunities to support it and what you can do to kind of support that legislation. We've also, we're a member of a number of, kind of coalitions and national groups that have called for the end of that as part of, honestly, it's really part of several different initiatives, but most recently it was part of the blueprint for a 988 implementation that we recently co-published with a number of other leading organizations. It calls directly for the repeal of that lifetime limit. And we certainly agree, we couldn't agree more that it doesn't belong anywhere. There's no good thing that could possibly come from it, and it's discriminatory and it needs to go.
All right. Oh, goodness. We had a few questions come in, sort of asking questions loosely related to the 988 implementation. So maybe you could sort of talk to folks about 988 and where it's at and tax roll.
Yeah, so 988 is one of those very broad topics that everybody's talking about, but I'm not sure that anyone's really specific enough so people kind of know what we mean when we're talking about it. So I'll give a broad overview and then just kind of some specifics about what it is that we have done while we've been working on the issue. But essentially, the National Suicide Prevention Hotline was part of legislation that was passed by Congress recently. And the idea is, that's a long number. It's hard to remember. We're going to transform that into a 3-digit number like 911. We're going to change that number to 988. And the idea behind that is that we want there to be a 911-like function for psychiatric or for crisis that is different from 911, so that we're not necessarily doing the same things for those kinds of calls that we would be for 911, which is one of the broader things that the attempt is based on, is the idea that we don't want to have the automatic response to a psychiatric crisis or to some kind of, to maybe a perceived risk for suicide to be a law enforcement response, or at least we don't want it to necessarily be a completely law enforcement response. There's a lot of things that go into that, but kind of the idea is we want there to be a response that is based on social services and based on medical treatment and things being available other than a law enforcement response, in the hope that that will eventually lead to less criminalization or a reverse of criminalization for these kinds of calls. And there's like the scope of 988 is a matter of a lot of debate. So what it has looked like on the state level is, each state is going to need to find a way that they're going to implement 988. And what that's looked like in terms of legislation is all of the states have filed legislation saying, yes, we're going to have this, here's the enabling legislation, and here's how we're going to try to pay for it. But a lot of them have done nothing besides that. So really the concern that has existed at the national level and among a lot of advocates everywhere, including I'm sure many of you, is, is this just going to be a call center? Is this basically going to be like you call 988, but it's really not any different? It doesn't do anything other than what we already were able to do by calling the other number. So there's been a lot of effort and a lot of meetings at the national level with people kind of figuring out, what is this supposed to look like? How do you make sure that there's actually a set of services that go along with this, that there's an actual process that is involved with this, so it's not the same patchwork of really inadequate care that exists everywhere else in our mental health system. And I will say that at the national level, there's really kind of a hope that this funding and this focus on crisis response could be an opportunity for like a Trojan horse reform of the mental health system overall, because you can't actually do a continuum of care for crisis response without a continuum of care. So this is an opportunity to, through the lens of crisis response, build parts of the system that don't exist and connect parts of the systems that don't connect. And so there's a lot of potential, but there's also a lot of worry that if we don't do an adequate job, it's just going to lead to either the same bad outcomes or even worse outcomes, because people will think that they've accomplished something when they really haven't. So a lot of the work that has been done around 988 is trying to really detail what needs to be part of this if this is going to work. And there are a lot, there's a lot that's involved with this 988 response, especially if you're going to look at it as like an opportunity to overhaul the entire system. That's a lot. There's a lot that goes into that. So there's been a lot of drafting and a lot of suggestions, and really, I don't know if Renee, if you've already put a link to the blueprint that we published in the chat, but I would encourage people to take a look at it because it really goes through all of the things that really need to be part of a continuum of care that accomplishes the goal of having crisis response not lead to criminalization. And there's a lot of concrete steps that you can take in there as a local advocate to kind of track what's going on at your state level and see, is my state actually going to roll out 988 in a way that complies with what we know needs to be part of the implementation if it's going to succeed. So really what it's intended to be is an opportunity for people to use this resource as an opportunity to kind of track what's going on at your state level and try to help ensure that 988 is something that can work for our loved ones. And kind of our overall thought about it is that, if our loved ones, if people with SMI are the people who have the most complex and the most difficult needs for crisis response, if you plan a system that can compassionately and safely address their crisis needs, you will be able to cover everyone else. So our overall, if there's one thing to take away from 988, it's that you need to actually plan a system that can address the needs of our population, because if you do that, it will succeed for everyone. So that's kind of the overview of 988. It's a huge issue, and there's a lot that's going to be coming out in recent weeks. So keep an eye on your email boxes. There are going to be opportunities that will identify for you to be involved at the state level to try to shape what your 988 response looks like at the state level, and to ensure that it's able to address the needs of our loved ones.
All right, we have a question coming in that says, I'm in a meeting in a couple weeks with our disability rights org leadership to discuss AOT. It's optimistic to imagine I will garner their support, as they have historically opposed it as coercive. Has TAC had any success in getting any disability rights orgs to support AOT, or is this a waste of time to even try?
Well, I will say, the one that I can remember is that the Hawaii Disability Rights Organization endorsed it. The amendment that would have, that you might have thought that they would not be in favor of it. So really, I think if disability rights groups are open to kind of seeing what it is that you're talking about, a lot of times they're not as likely to just automatically reject things. That's usually what I try to do, is it's try to persuade people who think that they oppose AOT to see it in action. We've brought groups to do field trips in Ohio, for example, to kind of see what it looks like, because it doesn't look like people think it does. It actually is, it's a collaborative process. It's not what you think. It's not like Law and Order. You don't go in there and you don't have a prosecutor, and it's nothing like that. It is collaborative. It is a feel good kind of a program. And if you can persuade people to come and check it out, you might be able to win them over, or you might at least persuade them to kind of stay out of it. If you're going to do legislation that's around it, or if you're going to implement it, that, they may not ever embrace it, and that's fine. Sometimes, maybe they would like to, but it's something that from the organizational level, they're really not allowed to endorse something like that. But you might be able to persuade people to just recognize that this isn't our area. We're going to focus on other things. Disability rights has a lot of stuff that they should be doing. They're supposed to be focusing on abuses. They're supposed to be focusing on trying to ensure that people who are looking to get continued treatment in, jails and prisons are able to do that. They've got plenty of things to work on. So maybe you can at least persuade people in disability rights that they will just kind of stay out of this area.
We're getting some comments in the chat. Same thing, right? Like having some success of explaining that we're on the same side. All right. There's been a couple questions about sort of criminal justice related things about addressing mental illness in jails and prisons and that sort of thing. So maybe you can sort of just talk about where TAC lands in that space.
Yeah, I mean, and it's a complicated issue because, obviously as an advocacy organization, our main point about this is that people with severe mental illness don't belong in jails and prisons. So like our main focus is go upstream, figure out a way that you intervene before it ever comes to the point where you need to call 911, and try to ensure that it's possible for somebody to receive medical care in the medical system on the civil side before it ever becomes something that's criminal justice oriented. And a lot of our effort is geared towards that because it really is the only way to be successful about this overall, is to ensure, I mean, once somebody has called 911, there's only ever limited control that you have over whether that becomes a criminalized situation or not. So the best thing that you can do is to try to ensure that you have workable laws that allow somebody to be hospitalized if that's what they need, so that they don't just continue to get sicker and sicker and sicker in the community until it's much more likely that they're going to encounter law enforcement and something might happen that could be construed either as a symptom or as a criminal act. So that's the idea, is that we want to make sure that we're doing everything that we possibly can to prevent this from ever becoming something that could be a criminal situation. With that being said, there are so many people with severe mental illness that are in jails and prisons that you can't just ignore that they're there. So definitely, we support legislation that bans solitary confinement because it's horrible for people with severe mental illness. It makes it so much worse. And I know that, a lot of jails and prisons will do solitary confinement because they're trying to protect that population, but that's not an adequate intervention. It might physically protect somebody, but it creates permanent psychiatric damage. So we will support legislation that tries to rid that practice out of jails and prisons. We certainly will always support opportunities to try to divert people out of the criminal justice system. Once, if somebody has been arrested and really what they've been arrested for is something that happened because they have untreated mental illness, we are going to do everything we can to try to promote ideas that allow people to be completely removed from the criminal justice system and put into treatment, which is where they belong. There are a lot of different states that are really trying to figure out ways to do that. And, some of that can be accomplished by trying to work with existing AOT laws. Some of it might require additional legislation. And, there's removing somebody from the criminal justice system and into the civil system, which is the best practice because it get somebody out of the criminal justice system where they didn't belong in the first place. There's also mental health courts. And really, as in most cases of our policy areas, you need a both and approach because you've got to try to reach as many cases where the real issue is mental illness. And you need to do that by trying everything, throw everything at the wall and hope that something sticks and that something that you've tried is going to acknowledge the role that untreated mental illness is playing and why somebody was in the criminal justice system to begin with.
Along that line, Nora just asked a question about regarding 988. Is there a concerted effort being made to train 911 workers to tell the difference between 911 call versus a 988 call? So I think 988 just needs a little clarity.
Well, there definitely are going to be efforts like that in some states. So I'll just say, 988 is going to be like our mental health systems generally, where there's going to be 51 versions of it. And I think if it works the way that it worked when 911 was created, which was actually not that long ago, it was kind of a mess at first. And there were different versions for every state, but eventually 911 became what we all think of it as today, where it's like you call 911 and you know what that means. And we will get there with 988. We are just hoping that we can avoid as much of a mess as possible when it's initially rolled out, so that there's, some consistency between states about what it means to call 988. So there definitely are states that have identified this priority, that they're going to train, their call center staff to kind of be able to tell, like, is this a 988 call or a 911 call? And it's critical that we figure out, 911 and 988 are related, and they're going to stay related. There's not going to be a complete bright line difference ever between those two things. But that's one of the things that we identified as, a goal and something that needs to be included in the blueprint for a functioning 988 system, is that we need to think of the call center staff as those who will actually try to diffuse the crisis, rather than just being as like a dispatch or a triage service, because that doesn't actually do anything new. We already have that. That's what 911 does. So we really are encouraging states to think of it that way, that what you're going to do is you're going to be hiring mental health professionals who are going to try to handle those calls themselves when they come in. And that's the ideal. Whether or not that is what most states do remains to be seen.
All right, and we have time for one last question, and this one was submitted online in advance of the meeting. It says, what can regular people do to further the rights, awareness, and funding for programs and policies that benefit people living with severe mental illness?
Okay, so there's a million things that you can do. So I'm just going to focus on the things that I can get to that are related to what we can easily identify for you. So first of all, I'm going to say, keep an eye on your email box, look for our emails, because every now and again, there's going to be things in there that are specifically, engagements that, that you can be involved with, and that might be time sensitive, where it's like, hey, there's a bill that's being heard right now. So definitely keep an eye on your email boxes and open our emails and see, if there's anything in there that you need to be involved with or you need to know about. Follow us on all of our social media. So definitely follow us on Facebook, on Twitter, on LinkedIn, our other social media. There will probably, if we have an activity that we're trying to have people involved with, it'll be on one of those. And, you don't need to follow us on all of them. If there's one that you particularly, we put them everywhere. So if there's an opportunity for you to get involved and contact your lawmakers on a particular issue, it will pop up in social media. So it's worth following us on one of those, so that you can be informed of what we're working on. I would say that it's a good idea to subscribe to Research Weekly, so you can keep an idea, of what's going on in the research community that's relevant to people with severe mental illness. I always find them fascinating. I'm not going to go out and get a subscription to every single one of these publications, so it's great to be able to read a summary. And then when we have our new advocacy newsletter, sign up for that, and then it'll keep you informed about what the different bills are that are in your state and what's going on at the federal level that you need to be involved with. Use our advocacy tools to jump in and get involved in these campaigns. And then, when you do that, if you see that we're doing a campaign that you think that other people should be involved with, share it on your social media, send it in emails to people that who you think might be interested. All of it is helpful. And for example, and we recently had one where we were encouraging Governor Newsom in California to sign a bill that had been on his desk, and we were waiting to see if it was going to be signed. And we were able to, have over 100 people write in, and those all went directly to him. And that's important for lawmakers to be able to see that there's support for a bill, and there's a reason why they should take it seriously. I would say, use the materials that we create that are shareable to educate state and local officials and lawmakers on the issues that, they may not understand in the kind of depth that we need them to, if they're going to really support legislation that we need them to support in order to help our loved ones. And then I guess I would say, finally, be our eyes and ears about issues that are affecting people with SMI. Like I said, we can't be everywhere, but you can.
Wonderful. And as the Director of Development, I would say make a donation to the Treatment Advocacy Center. So if you can visit our website and make a donation anytime through our very safe and secure donation page. That, I think, is the end of this. We thank you all so much for attending and spending your Friday with us. And thanks to Lisa for doing such a fantastic presentation. If anyone has any other questions that didn't get answered or needs anything, you can always email us at info@treatmentadvocacycenter.org. And I think that that's it.
Have a great holiday next week, everyone, and be safe.
All right, bye, everyone.